Today we have speaking Dr. Perry Halkitis, who is a professor of applied psychology and public health at the Steinhardt School. He's also the Associate Dean for Research and Doctoral Studies there and directs the Center for Health, Identity, Behavior, and Prevention Studies. I got a little bit of his bio from his Wikipedia page, which I was just sort of impressing the Wikipedia page. And,
doesn't everyone?
So we got a BA in biology and psychology from Columbia, 2 masters, one in education and one in educational psychology from CUNY, and a PhD in quantitative methods in educational psychology research from CUNY. And his research has primarily focused on drug use and sexual risk-taking, primarily among gay men.
Thank you. And thanks to all of you for being here. I'm very happy to be presenting to you some work that we've done over the last year and a project that we're about to submit to NIH. But as my colleague has suggested here, maybe it would be helpful if we could just quickly go around the room and just have everyone introduce themselves. Is that right?
Hi, I'm Chris Kovner, a professor in the College of Nursing, a public health nurse by training and practice. Sorry?
For Danny and Farzana and Raphael are my collaborators on the work that I'm going to be presenting to you today, and so asked us to join us in this conversation. But what I'd like to basically do today is 2 things. One, share with you some preliminary data from a cross-sectional study we undertook in the last year and a half, exploring syndemics in aging HIV-positive men, which sort of was the inspiration and sort of set the groundwork for the proposal that we're submitting to NIH Monday, a proposal on health, and it's done, on healthy aging in gay men. That's what I wanted to do today. So let me just sort of start by setting the context here. What we know about the HIV epidemic in the United States is that it is an aging epidemic, and by 2015, 50% of the individuals who are living with HIV in the United States will be ages 50 and over. And this is, of course, due to a combination of factors, including the implementation of effective antiretroviral therapies as of 1996, which have prolonged people's lives and keeping them healthy, but also at the same time, older individuals in their late 30s, 40s, and 50s seroconverting. So there is a demographic shift in the individuals who are seeing who are HIV positive, and a substantial proportion of those individuals ages 50 and over who are HIV positive are gay, bisexual, and other men who have sex with men. And you will hear me continually use this. I'm gonna go out of my way to use this term gay, bisexual, and other men who have sex with men, because the term men who have sex with men really bothers me, because it neglects the role that sexual identity has in health and in well-being. And for the most part, if you were to look at any study done on HIV prevention over the last 20 or 30 years, which have titles, have MSM in their titles, the majority of those samples, 70% or greater, are gay men. So when we're talking about the HIV epidemic in the United States, and we're talking about sexual minority individuals, and we're talking about men, we're talking primarily about gay men. So let's not forget that fact. There's a small proportion who don't identify as gay. This is a chart of what's going on in New York City and in the United States, and as you can see, again, the number of people who are ages, including those ages 40 to 49, continues to increase over time. So what do we know about the process of aging for HIV-positive individuals? Well, there's a belief that the aging process is accelerated. This is due in part to the chronic inflammation that is experienced by individuals who are HIV-positive. There is some evidence of neurological abnormalities and cognitive deficits that are more pronounced in HIV-positive individuals as they age. There is heightened risk for cancers, and you all know, or you may know of the work of Stephen Goldstone, who deals with HPV-related cancer in gay men. and what he finds is that individuals who have precancerous conditions, precancerous conditions in their anus, who are HIV positive men, 90% of them, even after they've had it removed, have a recurrence, as compared to only like 50% of those who are not HIV positive. So there is some kind of interaction that's going on with the HIV disease and these cancerous conditions. And from a mental health perspective, elevated levels of depression, which may or may not be due just to the HIV, but a combination of the HIV and victimization related to sexual orientation. I love this picture. What complicates matter is that at the same time, while gay men who are ages over 50 are experiencing these potential health problems, they also continue to engage in risk behaviors. Risk behaviors in the form of both sexual risk-taking behaviors and in the form of drug use behaviors. So this has been documented. We actually recently did a paper that just came out in AIDS Care, Pappas and Halkitis. We like to refer to it as the Greek paper. And in that paper, we show that that if you look at HIV-positive individuals in their 20s, 30s, and 40s, there's consistent unprotected sex, which seems to vary as the partner selection and the types of drugs that are used by the individuals. That changes over time. So I wrote, for HIV-positive men, 50 is the new 40 and the new 60. In fact, with the implementation of Viagra, which allows individuals in their 50s to have, very active sex lives, gay men who are HIV-positive in their 50s continue to engage in sexual behaviors, some risky sexual behaviors. At the same time, their bodies are experiencing these conditions related to their HIV disease, which make their bodies look more like 60-year-olds. So we undertook a study to understand the process of syndemic production. And as you may know, syndemic theory, first postulated by Merrill Singer, an anthropologist at the University of Connecticut, tried to understand why the HIV epidemic lodged itself in lower socioeconomic groups and in marginalized groups. And he was particularly writing about in 1994 and 1996 about the manifestation of HIV in Latina populations. And he argued that it is because these women were experiencing psychosocial burdens that made them more at risk for HIV disease. And in fact, when we looked at their disease profiles, not only were they having mental health problems and sex-related problems, but they were also having substance use problems. And these reinforcing individual epidemics of sex risk and mental health burden, psychiatric disorders, and drug use combined to create a syndemic. To get these epidemics fueled each other. And this is a theory that then Ron Stolz at the University of Pittsburgh took and sort of ran with at the end of the 1990s and applied it to studies of gay, bisexual, and other men who have sex with men, and particularly in populations of young men who have sex with men, looking at lifelong histories of victimization, psychiatric disorders that predispose these young men to risk-taking behaviors. And this got a lot of attention in the late 1990s and at the beginning of the O's, because when we looked at the new seroconversions that were occurring in the major metropolitan areas, they were occurring in primarily 13 to 29-year-old African American and Latino, gay, bisexual, and other men who have sex with men. So the theory provided a really effective lens for trying to understand why that segment of the population was seroconverting. So we thought, well, does the syndemic just go away after age 29? Probably not. And probably the behaviors and the conditions that are established in early life continue later in life. And so what we wanted to do is document syndemic production in older men, and in particular in HIV-positive men who were ages 50 and over. Came up with is we haven't put any data to this yet, nor have done any fancy structural equation modeling to prove it whether this is true or not. But I will tell you this: we have a paper coming out. If you look at all the research that's been done on syndemic theory so far, basically what's been done in those papers is that individuals collect data on psychosocial burdens, create a score by adding the burdens together. So if you're a drug user, you get a 1, and if you're depressed, then you have another 1, that makes you 2, and if you're victimized, you get 3, and you get this total score. And what they do is that they correlate that total score with sexual risk-taking behavior. And they have shown consistently that individuals with a higher psychosocial burden score are more likely to engage in risk-taking behavior. We've actually applied the model to a sample of 618-year-olds, which we have in our NIH cohort study right now, and applied structural equation modeling where we had indicators of mental health burden and drug use and sex risk, and actually showed that even in more complex modeling, that theory seems to uphold, and that it's actually probably really true. But anyway, this is our theoretical model for older men, where we argue that it's the same sort of burdens that create the risk behavior in these men. But in addition to thinking about the current burdens in relation to the risk, there's probably a lifetime history of a syndemic that also predisposes risk to these men. Again, that's a theoretical model for now. No data to support this yet. So we undertook this study to develop a measurement model, hopefully eventually in time, for that theory, and to examine the extent to which risk factors predispose risk in older HIV-positive men. And the project was called Project Gold. I think it stands for gay older dudes, but but every time I say that, my team yells at me. And we undertook this study in 2 phases. Phase 1, which was funded internally by Steinhardt, our Institute of Human Development and Social Change, 100 men. And we did quantitative surveys of those men, and also qualitative interviews informed by a methodology called the Listening Guide. The Listening Guide was developed by Carol Gilligan in the late 1970s, early 1980s. It is a methodology of inquiry that sort of looks at, it's kind of like a little hocus pocusy, but I love it. It sort of tries to look at the underlying logic in the words that people are using or not using in their conversations with you. I have no expertise in this, but my research team, who has sort of bought into it, has complete expertise into it. And it's this very interesting methodology where you create things called I poems and look for a change in tone in the conversation, and are looking for what the truth is, not only in the words that the individual is using, but also in the words that the individual is not using in having a conversation with you. That's the best I can do, guys. In phase 2, again, another 100 men. This time it was funded, I'm sorry for the typo there, by CFAR and CEDAR. Another 100 men, quantitative surveys, and this time, working with Dimitri Daskalakis, we were able to do oral, penile, and rectal gonorrhea testing and penile and rectal chlamydia testing of these men, because the CDC recommends testing of HIV-positive individuals, HIV-positive men in all 3 of those areas, but we're pretty clear that no matter who your doc is, most docs are not doing STI tests for HIV-positive patients in all 3 places. So we wanted to see what was going on. Okay, so to gather data on unprotected sexual behavior, we use something called the timeline follow-back method, and the same thing for drug use, the timeline follow-back method. And this is basically a calendar-based technique where we put a calendar in front of an individual, we circle important dates over the last 30 days in the calendar, and ask the individual about his or her behaviors, in this case his behaviors, on those days, and fill in the calendar. So imagine it was February, and the person's birthday was February 24th, and Valentine's Day is February 14th, and Groundhog Day is February 7th. Is that what it is? 2nd. Okay, so second, thank you for that. We circle those days, and we start with those days, and we say, on that day, did you have sex? What kind of sex? What did you do? What drugs did you do? And we work out from those important days, like Groundhog Day, and we fill in a calendar with very detailed information on the drug use and sex behaviors, not only looking at drug use and sex, but also drug use in relation to sex over a 30 and 30. So imagine, we have a lot of data on each of these guys for a 30-day calendar period. We did use the Beck Depression Inventory, did a PTSD measure, did a bunch of cognitive measures, including trails making and digit span, Wechsler similarities. We did a health-related quality of life scale. We measured adherence. As I said, we did testing for gonorrhea and chlamydia, self-reported recent and CD4 and viral load counts, and a lifetime history of recent and opportunistic infections, and then a whole bunch of psychosocial burdens.
How did you get them to participate in that?
I'll get to that in a second. I think I'll get to that, but let me finish this and I'll tell you. And then a bunch of psychosocial measures. Let me just say this about getting this sample. Oh, here it is. So we partnered with local community-based agencies. So we have very good working relationships with the ASOs in New York City. GMHC, Harlem United, GMAD, they love us, we love them, we work with them very closely. And they are very happy to partner with us to help us recruit for our studies. We also do in-person recruitment where we actually go to events. In this case, we actually went to the CBOs and did presentations and engaged people in a study that way. And we also did internet-based recruitment, both at sex sites and non-sex sites. And so for phase 1, we screened 262 men. So to get the 100, so 2.6 to 1, and 247 in the second phase. And I will tell you, the majority of the men who did not qualify for the study did not qualify because they were under age 50. So if we had if the study was like 40 and over, we would have had a much larger sample. We had, the men were knocking on our door. They were so grateful to be part of this study and couldn't believe that actually somebody wanted to study that, right? They were like, nobody wants to talk to us, like we're old, right? And they sat there and they were there for, some of them for very long periods of time, some of them experiencing, you know, we had to feed them a little bit, experiencing difficulty actually completing the executive functions task. It was difficult for some of them, but they were very engaged in the process and very grateful. And I cannot tell you the number of phone calls I actually got to my office thanking us for doing this study, because nobody had ever wanted to talk to them before, which was amazing.
Can
Yes.
you clarify really quickly for me?
Yeah, 6 months. But in the second phase, we didn't do that.
Okay.
Okay, so the final analytic sample, 199, ages around age 55, living with HIV for about 18 years. So a lot of these guys, 70% of these guys, were what we would classify as long-term survivors. They were diagnosed prior to 1996. And right now, I'm in the midst of writing a book, I think, I am writing it, on the life stories of long-term survivors. Men who seroconverted in the 80s and early 90s. Because I think somebody needs to write that book. And I think I'm the person to write it. And then about 44%, about half the sample had seroconverted in the 1980s, right? So they've been living with this disease for a very long period of time. In terms of race ethnicity, that's the breakdown there. You can see pretty good racial and ethnic distribution in terms of Black, Latino, and white men, some mixed race men. In terms of sexual orientation, gay primarily, although a substantial 18% bisexual, straight, you know, that's why we use the term MSM, and then other who chose not to give us an identity. In terms of educational attainment, about half of them had high school or less degree, right? So not necessarily a highly educated group of folks. Employment status, about 77% were not currently working. About half of those were on disability. And the whites in the sample had higher endorsement of both work and having a BA than either the blacks or the Latinos in the study. In terms of healthcare coverage, about almost all of them had some kind of coverage, and that's the breakdown there of what their coverage was. Some of them had more than one form of coverage, so individuals could have, you know, a form of coverage plus ADAP. But they all had some kind of coverage. They all were in some kind of consistent care. And if you look at where they got their care, about 50% at a private doctor or private clinic, 40% at a public clinic, 7% at the VA, and a small number, 3 used the ER as their primary care, source of care. So we looked at their burdens, and this is a distribution of the frequency of burdens that they used. We particularly were interested in marijuana, poppers or inhalant nitrates, alcohol to intoxication, not just alcohol. Not just, you know, a little glass of Merlot, right? Like you were totally drunk. And then indications of PTSD and of depression. So as you can see there, marijuana was the substance that was most commonly used by the men. About 20% of them had symptoms of PTSD. About 20 of them had symptoms of depression. If you look at the PTSD data and you look at it related to terrorist attacks, one of the papers I most recently said that about 15% of the individuals who viewed or saw the events of 9/11 have had PTSD symptoms. This is higher than that. I would argue and I would say that these men are experiencing PTSD. Their traumatic event is the AIDS epidemic, and they lived through the AIDS epidemic, and that is the trauma that was created in their lives, the loss of their friends, of their loved ones. So those rates of PTSD are not surprising to me.
How many of them have PTSD and depression?
Highly correlated. I think it's actually in the next table. Here are the odds ratios, actually. So when you look at, that's a great question. Look at the bottom right-hand corner. The odds ratio is 9.01 between depression and PTSD, right? So highly, highly related to each other, right?
So what's driving what? The PTSD is driving the depression. Which one comes out?
I don't know. That's a great question, right? All I can tell you is that they're coexisting, right? So again, here this is a set of odds ratios looking at you know, use of the drug or non-use of the drug in relation to the other drugs and in relation to of the psychopathologies with each other. So then we created, what everybody else does, you know, create a total burden score, right? So if you're depressed, you get a 1. If you've got PTSD, you get another 1. If you use marijuana, you get another 1. We created a total score for folks. And the scores range from 0 to 5, with most of the individuals having actually a 0. But if you see in the next chart here, a mean burden score of 1.34. That was related inversely to age and related to race ethnicity, with blacks having a higher score than Latinos, blacks having a higher score than whites, those classified as other higher than Latinos, and those as other as whites. And I caution you with the other thing, because I don't know what that is. It's like everybody else.
When you say it was related inversely to age, you mean that as age increased, mean burden score went down?
Yeah.
What do you make of that?
Yeah, so that's
What I make of that
surprising,
is probably,
maybe.
no, given that drugs were part of the burden score, it's not surprising to me that the
Because it
younger
tails
guys are
up.
probably using drugs more than the older guys in the South. Like the 69-year-old was probably not doing inhalant nitrates, and the 52-year-old probably was using inhalant nitrates, I think.
There's a danger there, though, because most of the cross-sectional data, I'm not sure you can look at the data by saying as you increase in age. I was going to hold my question until you talk about your study, because maybe over time, you know, then as age increases, what
Differences too. This is now their risk behaviors. So I broke it down by any anal with a negative or an unknown status partner, any anal with a positive partner, unprotected receptive anal intercourse with a negative unknown partner, insertive anal, receptive anal with a pause partner, and insertive anal with a pause partner. So you see slightly higher frequencies in terms of same HIV status behavior, right? Choosing what would be called in the literature serosorting, right? Positive men choosing other positive men with whom to have sex. Serosorting, right? So that's a term that's been tossed around for about a decade, right? Yeah, that people choose partners on their serostatus and tend to engage in different kinds of risk behavior based on their partner types. The problem with serosorting, HIV serostatus. The problem with serosorting is that often there are assumptions being made about the partner serostatus. They don't really know. They just assume, right? That's the difficulty there. So then we looked at the total burden score in relation to the risk, and for almost all of the behaviors, higher burden score, you know, was related to engaging in risk, right? The likelihood of risk was associated with a higher burden score. So consistent with everything that's been shown so far. And then we did a multivariate model where we looked at unprotected anal with positive partners and then again with negative and unknown partners, this time trying to control for the confounds of age, years living with HIV, and race ethnicity, and found in both the models that total psychosocial burden score was significant in predicting unprotected sex with either partner type. We identified 2 cases of rectal chlamydia and 2 cases of penile chlamydia in the sample, no gonorrhea in the sample. And that's just a breakdown of who we found it in. So there's no real pattern here, right? So like the rectal chlamydia, one guy was black, one guy was white, one guy was 53, one guy was 62, both gay, both living with HIV for a very long time. Similar with the penile chlamydia, one black, one Latino, both living with HIV for a very long period of time. No real distinct pattern seemed to emerge here. I bet that if we, if you were to do a more like a random sample of HIV positive men and test them for these conditions, you would get much more hits, because we're pretty clear, you know, just based on what the men reported to us, that they're just being checked for penile STIs and other STIs. So next steps in dissemination, these are a few papers that we actually have that we're putting together. One was an invited paper by Meryl Singer for Annals of Practicing Anthropology, and then a couple other papers we're in the process of finishing up. We are very dedicated to community dissemination. Like, this is like what we live for. And once a month we write an article for a local newspaper called Chelsea Now, which is a local area paper. And now we actually have just got invited by Michelangelo Signorelli to write pieces for Huffington Post in the Gay Voices section, so that's exciting. So it's very, very cool to us. And these are just like very, you know, like so fun to write, no references, just writing our, you know, writing about our experiences, you know, to a lay audience that actually, you know, gets a lot of play in the community, and, you know, builds a lot of goodwill in the community for us. Okay. So we did that study. And last year we submitted a grant and we said, why don't we do a longitudinal study to look at patterns over time? All right? Syndemic production over time with gay men ages 50 and over. Sort of do like the sister study or the brother study of the 18-year-old study that we're currently doing. And we went in the first time and got an okay-ish score, like in the 40s, and then resubmitted it and didn't get scored. So, you know, everybody knows how to play this game, right? So we sort of like dusted ourselves off and said, wait a second, maybe we're doing something wrong here. And one of the big criticisms was actually that and this is maybe the review panel, they didn't really believe we would be able to detect change over time in an older sample of men, right? In guys, like that somehow development stops at 18 and you don't continue to change after that. So maybe we didn't make that argument strongly enough. Nonetheless, we regrouped and we said we need to do something different. This was happening at the same time as the Institute of Medicine was publishing its report on health disparities in LGBT populations. So we thought, wait a second here. Here's what we should do. So we regrouped with my colleagues Danny and Rafa and Farzana and with Teresa Ashman, who's at Rusk, and with Dimitri Daskalakis, who many of you know, and collaborating with the CTSI, and said, let's do something slightly larger, a little more elegant, not necessarily just focused on HIV, and do a study called Healthy Aging in Gay Men. And this is the proposal that you've read the aims for today. So we are trying to, the rationale for this work is that obviously we know that in the next, period of time, the baby boomer generation, those born between 1964 and 1946, I say 1964 because I don't want to count myself as a baby boomer, but okay, are growing a growing group. We know the needs of baby boomers. We know, regardless of sexual orientation, or race, or any other factor, the needs of baby boomers as they age are going to be very different than the generation before, right? The expectations are different. We know that within that population are gay men, right? What we also know is that the Institute of Medicine report says very clearly that LGBT individuals experience health disparities, and that these health disparities both need to be understood as to why, and they need to be rectified. And so this is a really great report that just came out this year. And so we need to develop timely knowledge about health care and health utilization in older gay men. So we are trying to do this study where we want to document the physical, mental, neurocognitive, and sexual health of 1,200 men who are racially and ethnically diverse, and half of whom are HIV positive and half of whom are HIV negative. We want to also look at healthcare utilization in the sample, and then in our model to look at micro, meso, and macro level factors associated with these health outcomes, and to determine the extent to which age, race, ethnicity, and HIV status moderates or modifies these relations between the factors and the outcomes. So we are, yes?
How come you're limiting it to 69? There just really isn't anybody.
No, consciously 69, because we wanted sort of independent elders. And we want one, and number two, we wanted to really confine it to the baby boomer generation.
Okay.
Yeah.
So I was thinking there might be a retirement effect that's interesting to study, but you really only have one category there.
Yeah.
So.
Yeah.
It
It's a
affects
good
behavior,
question.
Although you showed not everybody's working.
And the shift to Medicare that happens.
It's, yeah, well,
65.
yeah. Do you guys want to add anything to that? You don't have to, I'm not pressuring you.
No, I mean, I think.
See what happens as people transition into 50.
What's the duration of the cohort?
Cross-sectional,
Oh,
cross-sectional stuff, yeah,
cross-sectional.
cross-sectional. So, and for our conceptual model, we informed it with three models, the sociological model of health, theory of syndemic production, and Anderson's behavioral model of health service utilization. And we brought those together to create this conceptual frame for our work, where we believe that micro-level factors informed by meso-level factors and nested within macro-level factors, community and neighborhood characteristics, engagement in social, religious, and civic organizations, and individual-level factors, those three, we want to do a multi-level model, inform our understanding of the health outcomes, again, the 4 health states, and the healthcare utilization. So this is just another map that shows what the main outcomes of the studies are. We're looking at health states and healthcare utilization. Health states, again, those 4 domains, and healthcare utilization, those 4 domains. So a cross-sectional study, newly recruited sample, 1,200 men, we know we can get them, using multiple measurement modalities, including computer-assisted survey, calendar-based methods, biologics, neurocognitive tasks, social support inventories, and assessments of all the antecedents, and of course archival data from the 2010 census to get at the macro level factors. And we will collect the data in 2 assessments. We will do the behavioral assessment at CHIPS at our site downtown, and then we will schedule the medical assessment that will be undertaken at the facilities of the CTSI. So we're collaborating with the CTSI to do this work. Sorry. The sampling frame is constructed along the 3 key moderators so that 300 men are in each of those age groups, 50 to 54, 55 to 59, 60 to 64, and 65 to 69. Half the sample is self-identified HIV positive, and they will bring us proof. The other half believes they're HIV negative, although we will test them, as we do with the younger cohort, and expect that we will identify positive results. I know we will. And we will set lower limits for race ethnicity, such that no less than 80 men within each age group identify as black, no less than 80 as Hispanic, regardless of race, and less than 40 as API. So we're setting lower limits.
Why so low?
Well, that's within each age group.
Oh, within age group. Got it,
Yeah.
got it.
So it'd be like no less than
80 out of
320
Got
are
it.
black men. Yeah.
Got it.
You know, and of course, but there's a lot of oral stuff going on with them, right? And there's different drugs going on. So there are developmental differences, right? There are also generational differences, right? I know this in the older guys we have what I call the AIDS generation, who came to age in the late 70s and 80s, the Stonewall generation before that, right? And these new guys, these 18-year-olds, you know, whatever you want to call them, you know, the Will and Grace generation, or whatever you want to call them. You know, it's a whole different mindset about how they're thinking about their sexuality and how they're thinking about their roles as gay individuals in society than a 59-year-old is. It's just really interesting. This is why, for me, the book that I'm working on is so important, because there is this segment of the population that went through this experience that we need to document. And David France, who's a really famous journalist and a documentarian, he created a documentary, How to Survive a Plague, that is being presented at Sundance, where he basically documents the whole ACT UP movement and what happened in that whole ACT UP movement. It's just like with phenomenal footage from like that period of time, which is, when I watch it, gives me goosebumps. We saw a preview of it at our research center. It's really, really great. So anyway, let me keep going. So here's the procedure. We'll recruit them. They'll come in for their assessments. Obviously, we will expect some men to be unexpected positives at that point. They will be connected to Dimitri for care. At that point, they could choose to be or not continue in the study. And then they will be scheduled for their medical assessments up here at the CTSI. So one time, Dimitri's team will also take responsibility for informing participants of any medical abnormalities, and making sure that they're linked to care. So if they're like, I don't know, their lipids are high or triglycerides are high or what have you, his team will convey that information to us for a research purpose, but we'll also be in touch with the participant to make sure that the participant is aware of this and is connected to care. Just our timeline. I don't know what that's about. So we will use structural equation modeling to build the measurement models, and then multi-level modeling to test the effects of the micro, meso, and macro factors. Just very quick depictions of what we believe that we will be developing in terms of the measurement models for overall health and service health utilization. For overall health, it'll be two-order model, a first-order model where the indicators load on the individual health states, and then hopefully the individual health states, maybe the individual health states load on a big macro factor. We don't know. Probably not. And then for service utilization, just a first-order factor model. And then, of course, this is just a depiction of what we believe we will be testing in terms of the prediction model. Again, multi-level models of the macro, meso, and macro factors predicting overall health. And let me just finish by saying that, you know, the IOM report says the creation of this multidisciplinary team is essential because the cooperation and interaction of multiple disciplines are necessary for studying and treating health, something I totally believe in. And I think we've done a really good job here bringing people together who are, you know, medical practitioners and psychologists and statisticians and neuropsychologists and epidemiologists to really create a team that I think is really robust, that can effectively do this work. And Anthony, our policy consultant, God bless him. Somebody's got to be able to translate this stuff effectively, and he's really good at doing that. And that's all I have to say to you today. And thank you very much for listening.
Thank you.